Hello, and welcome to our open forum discussion on referrals to care. If you haven't already, you may choose to look at the training materials that we provided on referrals to care, and we go over some of those statutory referrals and the difference of referrals and petitions and some different specifics about those referral pathways. But today we're going to hear from a panel of individuals on the ground at the county level who are navigating this referral process and some lessons learned that they have. Let's take a look at an overview of the discussion for today. So the first part, we're going to just focus on some high-level information from that training that I just referenced. And then we are going to turn to that panel discussion and also make some room for some open Q&A. So this is a live discussion that we'll turn to in a moment, but we really try to be responsive to questions and whatnot. So we're joined by some great panelists, and my colleague, Dr. Deborah Rose, will introduce those, but we'll be joined by Brian Roy from Napa County Health and Human Services Agency, Dr. Dana Meeks, who is a manager of clinical services at Sutter Alta Bates Medical Center. Also joined by Kara Palmer from the Alameda County Behavioral Health, and then the Honorable Carlene Navarro, who's the judge in Sonoma County. So now we'll turn to that live discussion and hear what they have to say and share about their experience with the referrals in care.
So again, as I did yesterday, I want to just start by thanking you all for choosing to spend your time with us. We really appreciate you coming back. And for those of you who are new today and couldn't join yesterday, you will see these slides are posted in about 10 days. You'll be able to catch up then. So just a quick high-level overview of yesterday's training. Let's go to the next slide, please. We distinguished between petitions and referrals. Again, petition is when somebody is filing a petition with the court directly, and referrals for this process that we're referring to are when somebody is contacting a county behavioral health organization and saying, I'd like to suggest that you consider this individual for the eligibility criteria and for consideration of a care petition. Either way, the process begins when a petition is filed. And we talked a bit more, we focused quite a bit, if we can go to the next slide, on the statutory referrals. And these are those that are the referrals that are identified and discussed, including specific pathways of how they may be processed through the care statute. And these specific ones are LPS facilities and are some court-to-court referrals. And so with that comes some guidance and language of how individuals who are on LPS hold may be referred by those facilities to county BH for consideration. So that's just a very high-level overview. We did discuss a lot more yesterday, which you can go back and take a look at the slides. What I'd like to do is I'd like to begin to jump into our panel discussion where we can go over some of the questions that were asked yesterday, along with some that we've identified for you. Okay. I am going to jump into this, and I will quickly introduce my colleagues who I appreciate you joining me. In no particular order, Brian Roy is with NAPA, with the Care and Mental Health Court, where he oversees the services and supports the services for care. Dr. Dana Meeks is a psychologist. She's the manager of clinical and psychological services for Sutter Alta Bates Medical Center, and she is in Alameda County. Kara Palmer, also in Alameda, is the senior program specialist for the Alameda County Behavioral Health Department, adult and older adult system of care, and she focuses on care court and FSPs, the oversight of the full service partnerships. So we'll have some good insight from both roles. And then Honorable Carlene Navarro is a judge of the Superior Court in California, specifically within Sonoma, and she oversees the mental health courts, including the mental health diversion, the FACT court, or the forensic assertive community treatment court, the care court, and LPS conservator courts. So I am so glad that you can all join me. Thank you. And I think that Leela may join us on screen as well. Many of you know Leela Kapoor. She is our legal SME, and Leela is certainly warmly invited to jump in with questions. And I encourage each of you to please share your strengths, your successes, and what challenges you faced in this process, because we're here to learn from you. So beginning, and I think we're going to focus a lot on those statutory referrals. I'd like to begin by asking, when you're thinking about a referral to care, whether it's a county LPS facility or court to care, what are some of the things that you're considering? Judge Navarro, I'm going to start with you.
Well, I think obviously depends on the particular case, because these are highly individualized treatment plans, and the statute is procedurally specific. One place where this question arises in my position here in Sonoma County Court is often in LPS court, where we're discussing whether a person is gravely disabled and should be conserved, or whether the person should continue to be conserved and a conservatorship should be reestablished. Sometimes after a period in treatment under a conservatorship, a person may be in a better position to try their hand in the community, but may need some extra support in terms of obtaining medication. I see a lot of people who have, difficulty timing their medication and making sure they're getting it on time. I hear people say a lot, I was doing well, but then I only had 2 days of medication left, and it was a Friday afternoon. I called the pharmacy and they couldn't fill my medication prescription for a week. And then next thing you know, we've got somebody deteriorating and becoming highly symptomatic. So sometimes it's just a matter of a person who needs some extra support in the community, but they seem like they want voluntary treatment, like they're ready to be in the community, and that it would just be helpful to them to have the extra support. And so that's a situation that arises a lot in LPS court, where I start thinking about a potential care petition and whether that person might be a good candidate for a care petition if I don't legally find that they're gravely disabled, for example.
And so how are you managing that in some cases there may be consideration or even paperwork for both conservatorship and for care?
So that situation just only recently presented itself and actually hasn't fully played out yet. But this situation I've seen arise in the context of the public guardian bringing a new petition for conservatorship because the public guardian still believes the person is gravely disabled. Recently, we've had attorneys from the public defender's office mention that their client contests the petition, does not believe he or she is still gravely disabled, and will be filing a care court petition. And my understanding is that the public defenders are going to be assisting the respondent with that, but that it would be a self-file on behalf of the respondent themselves, a direct petition. So like I said, that hasn't actually played itself out yet, but I imagine a lot of it will turn on whether there's evidence that the person remains gravely disabled or not. Because if the evidence to me shows that they're still gravely disabled, then I think the least restrictive placement or most appropriate placement is probably going to continue to be a conservatorship. On the other hand, if the evidence that I see in their petition tells me that they're no longer gravely disabled and otherwise meets the criteria for care court, then, that's the pathway I may be going down.
And you're in an interesting position overseeing mental health courts, LPS, and care. So I'm going to ask you to keep us on the loop and how that unfolds moving forward. We'll all have the opportunity to learn from that.
Yeah, we're also, something interesting that, since you mentioned that, Deborah, recently I raised a question to our mental health justice partners about making some potential adjustments to our court assignments so that I can potentially also take all of the IST, people who are deemed ISTs. And we're looking into that. It would take some significant restructuring, but it would resolve a lot of the issues that we're having between court to court in terms of care petitions, mental health petitions, and also LPS petitions, in particular where there are Murphy conservatorships and we have people moving between criminal, the
Right.
state hospital, and LPS.
And we certainly are hearing a lot of questions about IST referrals to care. And so I think that there is quite a bit of a focus on that. It's a perfect lead-in. I want to turn that thought for a moment to our colleagues at Alameda and ask, what are you thinking about, particularly Dana, Dr. Meeks, when you have somebody who is under IST in your facility?
Yeah, we try and identify as early as possible in their hospitalization that we might be working on a petition for care. I think we're in a unique position to be able, as an LPS facility, to be able to identify patients who have been presenting maybe more regularly, that they're not able to really sustain with the resources that they have in the community. So that's one way that we are kind of like identifying folks to file petitions for. We look at the criteria, obviously, if they meet the criteria, we look at that very closely. And then will they benefit from it? We engage with them to see if they are open to it. Sometimes when they're with us, they're still pretty unstable. And so that's a little bit of a process. We don't necessarily, wait until they're fully like, okay, I'm ready. A lot of times we go ahead and make the referral, and then it's a process, right? Like then when the team, once the petition is filed and the team quickly engages, then they can continue, they can start to build a relationship that will continue until there's a plan established. So that's kind of how we've been approaching it here. And Kara can talk more about it also.
Yeah, for the MIST and FIS, we do have a formalized process. For FIS, which are felony IST, the process, we have a court referral form that is completed by the judge or the clerk to refer the individual into care court. For the MIST process, those are processed through myself, and they are considered as inquiries. And we work directly with AFBH, which is the forensic department, to manage those referrals. So they start off as inquiries, and then we discuss suitability. And that's one of the words that we have come up with to discuss whether the individual needs either a IHOT, a AOT, or a care court referral. And so I have a team that I work with that we all come together and we discuss what type of resources does the individual need. And then with those MIST referrals, then we will determine how to refer those individuals. And so we do have a process for those two. As it pertains to LPS, many of the petitions that we have processed by Sutter have been individuals that have started on the TCONs. And depending on their needs, if they need subacute or if they need a referral to the community, those individuals will stay on that TCON until they are discharged. And so depending on their placement where they go, they may stay on the TCON until they stabilized at the subacute. And then what we will do is we will file a care court petition, that petition that comes from Herrick Hospital, say for instance, and we will file that petition. And then when the individual finishes stabilization at the subacute, we will engage with the individual while they're at the subacute, and then care court will pick them up when it's time for them to discharge from the subacute facility.
So let me just pause there for a moment and highlight something that you're saying, which is that Sutter will make the referral to your county behavioral health agency, and you are submitting the petition
Yes.
on behalf.
Yes.
Okay. Can you just like hum a couple more bars about that? I'm going to turn to Dana for a moment, and Brian, you're up next. Can you tell us a little bit about who or how the petition is being done, the paperwork for it?
Yeah, so the social worker and the psychiatrist work together to collect the information and kind of describe what's going on with the patient in the petition because they were in our care. We're kind of the best equipped to do that. What's going on with them? Here's their history, provide that. So we put it on the petition form, we send it to Kara, and then she does her process on her end, which includes an investigation and working with the medical director of behavioral health to actually sign it. So we are providing it to her with the understanding and agreement that it'll be filed. If there was some disagreement, she would reach out to us. So our intention is to have those filed, not just a referral, but that the petitions that we send will actually be filed and go forward. And so that's been our process that we've worked out. It's very smooth and very fast. It eliminates the need for a 30-day investigation period. I think our turnaround time, Kara's turnaround time is about a week, right? Like once we send it to you, it's about a week.
Yeah.
It's been in court. The case management team shows up really quickly. It's a very fast and streamlined process that then they can start engaging with the patient right away, even though the plan might come into play a little bit later down the line.
That's
Correct.
great. You figured out how to work out that partnership to make the process work.
Yes.
Brad, let me turn to you for a moment because you are also looking at partnerships and relationships in your community, and maybe you can tell us a little bit about the work that you're doing with your county jail in terms of petitions.
Yeah, I'd say our jail is staffed by county mental health, so that's a real benefit to us. And we've developed an internal referral form for all of our behavioral health subunits. So the jail is one of those. And within that, our kind of stated agreement with everybody is if you have somebody that you think qualifies for care, fill out, it's a very simple one-page form with just a few data points and bring it over to us. And if in looking at it, it seems likely that they meet criteria, I and my team take on the investigation and petitioning and declaration process. And then with that comes along an acknowledgement that sometimes we may not see the case the same way. And in those cases, we would let our partner within the agency know and encourage them to go ahead and file a petition if they still see it in the way that they referred it over, to kind of add accountability to us, put us on the clock for a more in-depth review if we haven't already done that, and to just kind of document that sometimes people are kind of just above the line and they might be below the line, and it might be beneficial to have a petition even if it doesn't go very far.
I'm going to shift just for a moment and ask you, Brian, and then I'll open it to others. Thinking about those non-statutory referrals, the ones that may be coming from a community partner, like a first responder or a provider, or perhaps a family member, when they're contacting the county to consider care, what are you thinking about? And how do you respond?
Yeah, so we kind of have an open line of communication. People can call and ask about the process for a petition. When it's members of the community that are lay, we kind of take that on a case-by-case basis. We've had some petitions that we have filed based on referrals from community members like parents. When it's kind of our professional partners in the community, the default is more helping them through understanding the forms and the petition process, so that we've kind of found that sets a helpful expectation of everybody continuing to do their day-to-day work. Like if it's somebody encountering someone from APS or wherever, and kind of troubleshooting any issues they have in the petition process. But again, for that reason of just being practical, if I have a bunch of reports and obligations directly from the court, and I'm also kind of automatically accepting in any community partner referral, to take on that process. If I've got 5 reports from the court, those are going to be the priority because I have a legal response time. And I don't want to unintentionally kind of gatekeep somebody from getting to the process when they need to. So I usually have a conversation with those parties around that and just the value that I see in them filing a petition to get everything rolling, to bypass, where I might have to prioritize.
And you illustrated that I think an important point is that you may receive referrals if your county does not agree with that referral. There's nothing that precludes that individual from either seeking help with the self-help center to file or to file directly if they're also an eligible petitioner.
Yeah, and if I may, I'll give 2 brief examples. One, I was working with a family member, a parent, who was concerned about their adult child, and we had some conversations about the benefit of potentially that individual filing the petition themselves, because she had a really good indication that if we filed it, that their adult child would not allow them in the process as a volunteer supporter. And so we had a conversation around the potential benefits of the family member petitioning instead, so that they would be able to be in that process more. Conversely, we have filed some petitions that have come as referrals from parents, and that has worked pretty well also.
Thank you. Kara, anything you want to add to that?
Yes. From the petition, the 43 petitions that have been filed, 19 of those petitions have been filed by Alameda County, and the rest have been filed by macro teams and family members. And so all of the petitions that do come in, we review all of them. And because what we're noticing is that some of the petitions that have been filed through the family members have missing information, maybe they haven't seen their loved one in the last year, maybe 2 years, when there is specific information that's on the petition that says there has to have been at least some engagement with that individual within the last 60 days. And so what we're doing is that we have been having discussions in our pre-meetings with the judge, with the team, about how best to engage with these individuals if they have not seen them within a long period of time. So it's very collaborative when there is missing information, or if there's information that we need from that macro team that has referred that client to us, that they come in during the initial hearing and discuss locations of how we can engage with those individuals. But most of those petitions that are filed, they are filed through self-help through the Superior Court system. And so they are able to help them file those petitions.
And Kara, for those folks who don't know what a macro team is?
Mobile Assistance Community Responders of Oakland.
Thank you. We all tend to speak in acronyms and forget that.
Yes.
What I'm hearing a lot of it, and Judge Navarro, I'd love to get a soundbite from you, is that you're really partnering with your courts and working through this process together collaboratively. Doesn't seem like there's a surprise that's going on in that process. Judge Navarro, what have been some of the protocols or ways of communication in your county that's been effective?
One of the things that we do, and we're still fine-tuning, is we have an email box specifically set up to go to contact behavioral health from the court. So if a court is ready to refer an individual from the criminal court, for example, to behavioral health for a mental health diversion evaluation or a care court evaluation, and we're still, like I said, fine-tuning that, they can make a request directly to behavioral health through a specific email box. Forensic behavioral health at sonomacounty.org, for example. There's a 2-week turnaround time relative to the statutory requirement for behavioral health to respond and give an opinion on mental health diversion or care court directly to the criminal court. And then if the criminal court, if the person is eligible or qualifies for a care court or mental health diversion, what have you, they go from there in terms of starting the process.
And I know that you're also meeting with your behavioral health agency at least monthly. Maybe you could share a little bit about how you've used that form to talk about referrals, or at least referral pathways.
We meet monthly. We talk about all of the different aspects of our mental health courts, what's working and what isn't. We can make adjustments to our processes through the feedback that we get at those meetings. Where we have everybody included in the meetings: behavioral health, county council, the court. We have some representatives from our community health clinics, so that we're keeping the community engaged in terms of organizations that see a lot of care court petitions or have a lot of clients who are participating in mental health diversion or some of our other mental health courts. So it's helpful to have regular meeting in place so that we can talk about any issues that have arisen between the time we last met and our next meeting.
Thank you. I mean, so far, the common theme that I'm hearing from everyone is it's really about that collaboration to set up systems, to test them, and then to keep reworking them. I know I'm bouncing around a little bit, but I have a list of questions, and I want to make sure that I'm trying to cover as much as possible. Sticking, Judge Navarro, one more question though. Is there a system set up yet? I know it's still pretty new, for how you're communicating with your county BH agency for those LPS or potential LPS referrals to care?
At this point, since, I'm kind of in a unique position, because if I meet somebody in LPS court and they seem like a good candidate for care court, at this point, I'm making a direct referral to the public guardian who's there in the room with me to consider eligibility for a care court petition. And what I'm going to start doing going forward is setting a status review or a control date so that I can check in with them about the status of the investigation or potential petition.
That's great. So let's, I think we've talked a little bit about sharing of information between court to court and facility to behavioral health. We've been asked, and I'm wondering if folks have thoughts about closing that loop. How are those referrals? Dana, you're nodding, so I'd love to ask you. You're on the other end. How do you find out what happens after a referral's been made? And Brian, I might ask you, how are you working with those referral sources to let them know what's going on?
Yeah, we work pretty close with our Alameda County partners. So we kind of don't find out, and that's a good thing, right? Like if we're not hearing back about someone that we've referred to care court, that probably means that they are in good hands and where they need to be and getting the support that they need. So once we discharge the patient and we kind of put them in the hands of the next lower level of care, and there are patients that we continue to follow a little bit if there's things that we need to particular items that we need to follow up on. I was nodding my head. I'm curious because we primarily file petitions in Alameda, and we have this really nice system worked out with them. But we take patients from all over the place, and actually one of the places we take a lot of patients from is Sonoma County, because we have it's Sutter Santa Rosa. We have an emergency department there that's very impacted all the time with psychiatric patients, and we take a lot of them. But we don't have that same system worked out. And one of the challenges is we've worked out with Alameda County this process where because in Alameda County, we only have 5250, we don't have 5270. So the longest we can hold somebody involuntarily is 14 days. They often need longer than that. So we end up using a conservatorship. And then with Alameda County, we have worked out that they can be on the conservatorship and we can file the care court petition and get that started. And not having that worked out with other counties does provide a barrier for us because we are put in a position where they tell us we have to choose, right? Like you can't have them on the TCON and the care petition at the same time. We've had not with Sonoma, but with another county, we've had them dismissed for that reason. So like working out the process to where that is possible, like particularly in our situation, there's just no way for us to always be able to pick, right? Like sometimes they need both to exist at the same time to kind of carry them until they're ready to accept that and are ready to engage in the plan. So I'm just wondering, like, what is the best way to go about that? Like, how do we build those relationships with, yeah, I've been thinking the same thing about Contra Costa County. I'm like, how do I even start this process, right? It was easy with Alameda because we are really engaged with each other and we're good partners, but the counties that I have less connections with, I don't know what the best way to go about like establishing that is with the courts and with the, with the county behavioral health leaders and, and the people in charge of care court, like how, but I'm just wondering what the thoughts are about that.
In Sonoma County, we have a team of clinicians who are tasked with overseeing care court and care court petitions, and I'd be happy to put you in touch with them to see if maybe you could work out some sort of referral system or form that you send to the, care court contact in Sonoma County to consider the filing.
Yeah. Great, thank you. And I'm just wondering if maybe that is part of like the overall agenda, maybe of CARES, right? Like to establish some kind of system to be able to make these connections with different counties, different facilities, different, providers. I'm hoping that like that architecture might get, and I think it's there a little bit already. I think there's a list of like people from the various counties who are like the contact people, but I'm just wondering if there is like just an infrastructure thing that would be super helpful to all of us just in making these connections so we have processes worked out.
I think, that's something that we've been working on in terms of mental health diversion in Sonoma County, which has been around, a little longer than care court. When I came into mental health court in Sonoma County, it was January of 2024. And at that time, I realized, at least in mental health diversion court, the vast majority of our mental health diversion participants are being treated through the community health clinics. So, for example, Sonoma, Santa Rosa Community Health, Petaluma Community Health, etc. But there was no communication going on between the court, behavioral health, and those community health clinics in terms of what mental health diversion is. What does the treatment plan look like? Why are there certain aspects, focused on in a particular treatment plan? So what I did in Sonoma County was I sent out invitations to all the medical directors and different prescribers and therapists at the community health clinics so that we could all sit down. I could show them the statute. We could talk about what the statute looks like, what was the legislative intent behind the statute, how does mental health diversion court work? We had a lot of concern from clinicians about sharing confidential mental health information, concerns that if they give the court information that could be seen as negative about a patient, that they'd be booted out of mental health diversion and end up in jail. And so clinicians are understandably concerned about their patients and giving the court information. And so it was really helpful for me in the mental health diversion context to get together with them and say, here's how it works. Here's what my legal obligations are. I believe in harm reduction. Let's talk about how that works, but how that differs between a clinician and the court, and how can we work together to really maximize the benefit of mental health diversion for this particular patient. So I imagine that something similar to that is going to happen with care court. We were a cohort 2 county, so we're still just in the beginning stages of what our processes look like. but it's going to be really similar, right? A lot of the same patients. I would imagine we're going to see overlap amongst patients and amongst providers and clinicians. And so I envision the same thing happening. And I would encourage you, we can exchange information, to reach out to me, and I can put you in touch with our care court team so that we can start building relationships in the care context too.
And I imagine that offer is true for other counties as well, because we certainly know that many individuals that are being served by care between counties may reside in one, have been filed in another, family, have been hospitalized or in jail. Let me ask a question about that, because Dana, and this is for the whole group, you work with folks who live counties outside of Alameda. We've been asked, how do county BH agencies, how can they respond to referrals that are coming from different counties? And I think it's happening, we're seeing it more with LPS facilities, as somebody who is currently on an involuntary hold, who is going to return to another county. And what does that outreach and engagement, what does that initial referral process look like? So I'm going to open that to anyone. Have you had that experience?
I'll just say we haven't had that experience, but here in Napa, we have a pretty good sized case management unit that handles all of the conserved clients. And so if there was ever something that was going to be kind of coming down the pike, one, that team always handles any step down from LPS facilities. If it's kind of you're staying on LPS or they've worked their way through agreement to get down from there. So the only area that I see we would probably jump in would be if somebody contested and was either potentially going to succeed in that or did and said, all right, I'm out of here. I don't want anything to do with anybody, at which point we would probably come in, and then we would have, a ton of institutional knowledge and data around them to get running with outreach and react quickly to try and scoop them up.
Yeah, I think we've encountered just the differences between the different counties as a bit of a challenge. Who to contact, how to go about it. Like, do we want to do a referral or a petition? We tend to err on the side of filing petitions because the referral process in our mind is a by the time it's investigated and they decide whether or not to file a petition, it's likely the patient isn't going to be with us anymore. So we have no way of knowing that it's actually, that they're actually being engaged with. At least if we are able to file a petition, we know for sure that there's going to be, that it gets on the court's radar. There's there's going to be at least some engagement. And so that's been our tendency. But then there's these differences in e-filing, right? Like not every county, you can't e-file in every county. So we've considered like mailing it to courts. And then it's like, and then we really probably won't know what happens. I mean, sometimes we will, because if a hearing ends up getting scheduled, theoretically, we would be called to testify. That hasn't happened yet, right? Like, so because our process with Alameda has worked out to where we aren't in that role to attend the hearing. But if we were to do that in other counties and we filed the petition, then we would probably, after the patient is gone for a good amount of time, then be participating in the hearing.
Mm-hmm.
So that's a little bit challenging, like to think about the referral versus the petition and what the outcome will be when we don't have a process worked out and we don't have an easy way to do one or the other. Really, we don't have a straightforward path to e-filing or to filing in general, and we don't have a clear path to referring because we don't have a process worked out yet. So it's just the differences between the counties does present a little bit of a barrier.
And certainly we've heard questions if somebody is in a county LPS facility that's far away, does our team go in? Can we do it telephonically? Can we do it by video? How do we outreach and engage that person and come together? So I do agree. I think that counties and facilities are still trying to figure that out and what those best practices might look like. Any other thoughts on that? I'm going to shift a little bit. We have about 15 minutes left, and I would love us to talk about trust and engagement, not only with each other and with the system that you're developing, but with the individuals that are being identified for care. What does that look like? Kara, I'm going to start with you. What's been effective when you are either initiating a petition or we're talking about referrals, receiving a referral? How does one begin?
So with our process, we receive inquiries. That's where they start. So we document on our tracking documents. We document the inquiry, and then we have a team of 3 of us that just talk about the suitability, as I said before, and then based upon the need, how many times this person has been engaged in the community and by behavioral health, then we say, okay, Care Court would probably be the best program. And so from there, we whether that individual has been already connected to an FSP team, we engage with that FSP team and kind of have a discussion about what has worked, what has not worked, what would be beneficial for this individual. Do they like a certain area, different things like that. So we talk about that. And then from there, we complete the petition. We have the FSP team complete the declaration if the individual has not been on a 5250 within the last 60 days. And then when they return that back to us, then what we do is we, myself and county council, review the petition and the declaration to make sure that all of the questions have been answered and that there's enough information for the outreach and engagement team. And so we make sure that that looks well enough to file that petition. And then we file the petition, the county council files that petition, and then it goes to the outreach and engagement team that has the benefit information, all of the information that has been discussed previously with the previous FSP team, any pertinent information that would be beneficial, some historic facts about what the client has suffered with that might be helpful to the team. And then from there, we start to collaborate. In Alameda County, we have meetings every single day about Care Court. So we have 2 meetings that are designated with the public defender, and then the other days we have court, and then the other 2 days we have engagement with the actual outreach and engagement team. So it's very collaborative. We discuss everything about the client. And then we just make sure that we have a full kind of breadth and length discussion about what is helpful, what's not helpful, what does the client need. And then if we need some assistance from, maybe it's a petition that came from a family member or came from the macro team, which is a derivative of the fire department, then we try to say, maybe we need more information from those teams that can help us. Maybe we need some more information from the family. And of course, the outreach and engagement team deals with the release of information to talk to the family or talk to whoever they need to talk to gather that information about how to find this individual. So it's very collaborative. We try to engage as many people as we possibly can in this process to make sure that we can meet the needs of that client.
You're on mute, Deborah.
Well, that was bound to happen at some point. Sorry about that. So Brian, you and I have talked a little, no identifying information, of course, but you've shared a little bit about some of the approaches that you've used to engage respondents for care. And I'm wondering if you could talk a little bit about some of the decision points and how you've approached engagement and care.
Sure. Yeah, thank you. So on the ones where we've kind of had somebody referred by a family member, we've really tried to be mindful of engaging them within the outreach as much as we can. So maybe making sure that the referring parent is there as much as they are able to, as much as the potential respondent is open to it. That kind of helps because some of our clients are not open to signing a release if we ask them to, but if their parent is there and we show up and we ask if it's okay if mom stays, they typically say yeah. And then we are able to kind of gain some trust and build out. And I would say that our approach has really been to build rapport through being completely transparent about what the program is and what our aims around potentially inviting them in or going to the civil court and asking for an order to get the opportunity to work with them, even though they might not like to work with us. And so just today, I was having a conversation with somebody who does not want to be involved in care and is really kind of hanging on by a thread. And we had a conversation of leaning into the fact that this person doesn't want to do it, and that if he would allow me to get him up and running with our medication clinic, that we could potentially kind of push out the initial proceeding a couple of weeks to demonstrate that he's working on getting stabilized, come back, and potentially he could, with his attorney, win in court and send us on our way. That didn't really carry the day, but I feel like it's always important to give everybody a really clear idea of how they can avoid it if they want to avoid it, so that then when they don't take those opportunities, it's also not going to be a surprise that I'm still in the mix and that I'm going to move forward with trying to do these things I've been talking to them about.
And you had one instance where you worked with an individual to create a recovery package or plan prior to submitting to care court.
Yeah, we've had two voluntary entries into care, and actually for both of those individuals, we were able to essentially have the care agreement inked along with the petition and declaration, so that then by the time we got to our initial hearing, we could just get right off to the races and move forward rather than coming back later. And that really developed a lot of positivity around the program and buy-in in developing a really robust treatment plan that included addressing, all of their treatment needs across substance use and psychiatric treatment. But also, one thing we always ask people is, what do you want more of in your life and what do you want less of in your life? And then we try and build an agreement based around some of those identifiers.
I like that. Thank you. Judge Navarro, we've talked about building trust and rapport, and you've shared with us some really wonderful thoughts from the bench. Can I turn the question to you?
When Brian was just talking, it reminded me of something that's been coming up in some of my other mental health courts. And so I work really hard to build relationships with the participants, because I think that that's a really important aspect of mental health court, right? Here we are, strangers to each other, and I'm ordering people to take medication as recommended and prescribed, and I'm ordering them to go to therapy, even though their therapist is going to provide a progress report to the court that doesn't get into, the substance of their confidential communications, but the court asks for therapists to let us know if somebody is using drugs or alcohol. And so there's a period of trust building where I try to get participants to understand that I am asking your therapist to tell the court if you're relapsing and using drugs or alcohol, not because I want to punish you, not because I'm going to remand you into custody, into jail because you have a dirty test or you said you were using, but because I need to know the best way to help you and the best way to work with your treatment plan so that it brings, like Brian said, what you want more of into your life. And for a lot of our participants, sobriety is, a driving force in their treatment plans. And we talk a lot in mental health court about the two most important things to focus on, being clean and taking your medication as recommended, because everything else we can do together. We can talk about jobs, we can talk about community service and building a resume, we can help you navigate housing. But if you're using or you're not taking your medication as recommended and you become symptomatic, then it is very difficult, if not impossible, for us to get to everything else. And so I spent a lot of time trying to build trust amongst the participants in my mental health courts so that everybody understands that I am not here to hurt you and punish you. I am here to support you and help you build a treatment plan that works for you so that you can go forward and have the healthy life that I know you want to have for the vast majority of the people in my courts. And so something that's been coming up that's new is sometimes there can be some anxiety around participants from mental health court or fact court, which are my participants who are on felony probation, or even LPS court, people who are on conservatorships and have been comfortable on a conservatorship. And I've started mentioning care court to them because there can be some of this buildup to a graduation date or a step down that makes people really anxious. And so I worry that they're going to leave us and feel like there's something missing in terms of their supportive community. And so I've been mentioning to them, care court is maybe something you want to consider. Let me know if you want to talk more about it. Because essentially what it'll do is keep this treatment plan that you've been building with us in place. It's totally voluntary, right? And it just helps that person continue to have support in the community when they leave one program and move on to, independence in the community. And so I talk a lot about building trust in that way.
Thank you. Thank you. You also mentioned medication. Can we talk a little bit about how you approach including medication on a care plan or a care agreement?
Yeah, we have it.
You're on mute. Sorry.
Sorry about that. We're still in the all of our care petitions are still in the initial and investigatory phases. So we have.
Sorry, you're back on mute.
I was unmuted. It's kind of going
The
on.
mute is going on and off, and I'm not sure why. So just keep an eye on it. Sorry about that, Jen.
Okay, I'll keep watching. It's going on and off on its own. So what I was saying is a lot of our care petitions are still in all of them are still in the investigatory phases. We haven't actually reached a point of making agreements or getting to the care plan stage and talking about medication. I imagine, like I said earlier, it's going to play out much like it does in mental health court because in mental health diversion court, because most of my participants, or I shouldn't say most, some of my participants are hesitant to take medication. They don't like the way it makes them feel. They have side effects that make them feel like a zombie, they often tell me, or they can't get awake, or they feel like they're foggy. We also have issues with a lot of our participants who are very reluctant to stop smoking marijuana and who tell me marijuana is all I need. I've been getting by for years and that helps soothe my anxiety or, calm my symptoms. So one of the things that I did, we were having trouble communicating with prescribers. And I'd have people who I knew had a diagnosis of schizophrenia or bipolar disorder, for example, which is usually contraindicated with marijuana use because it can cause paranoia. But I had a lot of participants coming into court and telling me, Judge, my prescriber says I don't need any medication, that I'm doing fine, and that I could, I've been using it for years and I'm doing fine. And I'd look at the diagnosis and say, well, I have some questions about that. I'm going to need a letter from your prescriber saying that marijuana is not contraindicated with the medication they've prescribed and tell me what they've prescribed. And that resulted in a lot of very cagey letters from clinicians who didn't want to provide this information to the court or didn't know what, the court was exactly asking for. So we created I created a medication recommendation form where I could just very clearly say on one line, here I am the prescriber for this individual. We have a little HIPAA advisement on there. Here's the diagnosis. Here's the recommended medication regimen. The patient has agreed or not agreed to this medication regimen, and marijuana or THC rather is contraindicated or is not contraindicated. And it's just a series of check boxes. I actually met with the medical directors from the different community health clinics to help us fine tune some of the language, because there was a lot of concern around THC, because community health clinics often have federal grants and don't want to even discuss marijuana or THC at all, even if they're just saying, generally speaking, THC is contraindicated with this diagnosis, So it's helped to have the form where we can just very clearly get the information that we need about medication. And then usually what I tell people about medication is, will you at least try it? One of the requirements for this program is that you at least try it. If it makes you feel awful, if it's causing you terrible side effects, I'm not going to require that you keep taking a medication that is hurting you. But will you at least try it? And then let's discuss how it makes you feel as we go forward. And one of the things I always tell the participants is, if you're sleepy, you're feeling like a zombie, don't just stop taking it on your own. You've got to call your prescriber, and the court will follow up with them to make sure that you get a phone call. And I have case managers who help me with that. And I've had a lot of success with people, taking that initial step to just trying it, and learning how to advocate for themselves with their prescribers. Sometimes they come into court and tell me, Judge, he doesn't listen to me, or I didn't know what to say, and it's making me feel really sick. It hurts my stomach. And I say to them, well, let's practice that. What are you going to go in to say to your prescriber, when you see him next? Let's get you an appointment, and you can go in and say, here's what I'm taking and here's how it's making me feel. And I often have them repeat that back to me. And that's been pretty successful, because they come back to court the next time and they say, I told him like we practiced and he made adjustments and I'm feeling better. So I think if we could just get over that initial hump a lot of times, where we just get people to try it and learn how to advocate for themselves with their prescribers, people can naturally see the benefits of that.
And you are certainly carrying the weight of the black robe, which we talk about all the time, and the influence of the black robe effect. I want to thank you. I also want to thank everyone. We're over. I have not done my job. I'm committing to time. So I'm just going to quickly say thank you. I could stay here indefinitely. I'm going to turn it back to Patricia. And again, we value all of you, what you're contributing, and to the listeners.
So that concludes that live discussion panel. And again, I hope it was helpful to hear about what other counties and CARE Act implementation partners are doing on the ground to work out how to refer individuals to the CARE process. Wanted to point out some key resources. We do have a training and resource library. We list a number of upcoming trainings. We have a county directory and FAQs that you can point to. So we link to all these materials, so you have these materials available for you. There are a number of ways to contact us. So we have a listserv where you can receive notices for upcoming trainings and different TTA-related information. There's also a training and technical assistance request form, and one specific to data. If you want to provide general feedback, you can also do that. And like I mentioned, our email address. There really is no wrong door. If you have a question, you don't know where the information is, you can go ahead and email us at info@careact.org. Thanks for joining, and let us know if you have any questions.